I appreciate you guys giving me time to meet with you and get a chance to talk about pharmacy benefit managers. So today was the start of legislative days in Salem. So I just got back about an hour ago from being down there and had 5 great meetings with representatives from the House side of things on both sides of the aisle, including one meeting that had the OHA director, Dr. Hothy, participating. So it was good to have her included in those meetings. But to let you know, I'm with the Oregon State Pharmacy Association. I'm the executive director. I've been here for about 4 years now in this role, and we represent the community pharmacists across the state. So my dad, as Mike mentioned, was a hospital pharmacist at Samaritan. So he would have been with OSHP, which is the other group that we work with, and they represent the health system pharmacists. But we collaborate on practically everything we do legislatively. So and quick shout out, I see a couple of our members here, Roberto Linares and David Debsing, who are OSPA members. So I talk about to throw in their 2 cents about what they're seeing with the PBM issues. But for those of you who haven't heard of PBMs before, it stands for Pharmacy Benefit Managers. They are the middleman in between the pharmacy and the insurance company. So they're there to process the claims and do all the paperwork, and that's how they kind of started, was to be some back in the 1960s, to be a third party outsource type thing to go ahead and make administrative processes easier. Over the past 60 years, they have morphed and become huge companies that have also done something called vertical integration, where the health insurance, the PBM, the pharmacy, the specialty pharmacy, the PSAO are all aligned. And there's 3 major PBMs across the country: CVS Caremark, Optum, and Express Scripts. So CVS Caremark obviously is CVS, Optum is United Healthcare, and then Express Scripts is Cigna. So those 3 nationwide have about 80% of the business for pharmacy benefits across the country. So with Oregon, we're very fortunate that Senator Wyden is the chair of the Senate Finance Committee and has been a friend of pharmacy for several years, and is trying to do work at the federal level to rein in PBMs and hold them accountable and keep pharmacies in business. So he's got a lot of work that he's been doing on his end, but we've also been doing our work at the state level, trying to pass legislation and get PBM reform in place for the state of Oregon, because currently Oregon is the second worst in the nation for patient access for pharmacies. The only other state that's worse than us is Alaska, which makes sense for Alaska, but there's no way that Oregon, being as progressive as what we are for healthcare and all other services, should be the second worst in the country. So there's an AP report that came out a couple of months ago with that information, and it's we have a lot of pharmacies that are closing on a consistent basis. Last year we had 36 close in Oregon. This year I think we're up to 14 or 15, something along those lines, but we're not having pharmacies open because there's not enough revenue from the process because of the PBMs to go into the system. PBMs, as the middleman, contract with the employers and the insurance companies, and they're the ones who are setting the prices for the drugs. So you could have the same drug at one, say $10 for one person, and then the next person comes in for that exact same drug and they're charging $110. So it's all based on what the PBM determines the price to be. And with the reimbursement amount that they're giving, there's the cost of the ingredient that the pharmacies purchase the drug for, and then there's the administrative fee for keeping the lights on, staff, rent, all those types of things. So that currently there's about, out of 100 prescriptions, 75% of them are underwater on the cost of the drug. The other 25% make up the rest, and they're inflated. And then the dispensing fee, which is the one to keep the pharmacies open and handle all the cost of doing business, fluctuates depending on the PBM and the setup. So you could have, you know, one PBM give you a dispensing fee of 10 cents, and the next one gives you a dispensing fee of $10. So it's all variable. And when you're in business, it's a very difficult model to try and stay in business, which is why you see the headlines of people closing down. And that's very concerning for those that are in the rural areas. I live in West Lynn now, no longer in Corvallis. And so I am in a position in the state where I have options to go to. Those lines are extremely long, but at least I have those options available to me. I had one of the meetings today was with Representative Smith, who handles Murrow County out in Eastern Oregon. And two of our pharmacists, John Murray and Ann Murray, own 3 pharmacies over in that area. And they have patients that are driving an hour to 2 hours to get their medications because they don't have any other options available. So those rural communities are really suffering. One of the other meetings we had today was with Representative Javadi, if I'm saying his name correctly. He's in the Tillamook area. And they've had pharmacies closed down. They only have a Fred Meyer's and a Safeway open right now. And the information that we've received is that Safeway is going to shut down in the next 6 months. So that's incredibly unfortunate for the people that are in that community, because along those coastline areas, there's not other options to go to. There, PBMs and insurers will talk about mail order pharmacy, which is convenient if you have a medicine that you're having on a regular basis. But if you take your child to the doctor and need amoxicillin and need to have it filled at the pharmacy at 10 o'clock at night, you know, you're not going to have that option in a lot of areas because of pharmacy closures. So there's only so many that are open late hours, and then there's others that have reduced staffing and reduced hours during 8 to 5 as well. So but you need to have your child get that drug, because we don't want kids crying and being hurt and pain and all that. So, and you know, that's just children that we're talking about. You know, everybody needs access to their medicines and have that opportunity. So when I say that Portland is the second worst in the country, it's unfortunate that we're in that situation. There is Representative Wallen from Medford, who had a family member recently undergo surgery, and they had to go get some medication in the Medford market. So they went up to CVS, and the sign on the door said that they were closed that evening, and that the next closest 24-hour pharmacy was in Beaverton. So I'm not sure what they ended up doing, but I know that they didn't make the 4-hour drive from Medford up to Beaverton to pick up a prescription. So those are some of the problems with PBMs and not allowing or not reimbursing the pharmacies enough to keep them in business and operating at the a level that they need to. So we have a PBM bill that we've been working on since June. Well, actually, I guess we could go back to the 2024 legislative session with Representative Rob Nose, the chairman of the House Healthcare Committee. He went on record during the 2024 legislation saying that our bill that went through during that session was gutted, essentially, and that he was going to come forward. Hi, sweetie. This is Macy, so hi, sorry about that.
Banana.
Yes, banana. Thank you, sweetie. So thank you. In House Bill 4149 got gutted compared to what it was the previous year in 2023. And so the legislation, excuse me for just a second.
Thank God for children.
That's cute.
Day. Oh man.
Yeah, thank you. So for the he went on record saying that he would bring forth a PBM bill for this session, and what he's done since January, or excuse me, since June, is hold work group meetings with us and the insurers and the PBM lobbyists for 3.5 hour meetings. I think we've had like 6 or 7 of them since June, and we have a proposal for a bill that we've submitted for legislative concept, and they'll end up writing it up similar to what House Bill 3013 was in 2023. But what it's going to ask for is getting the price of the drug reimbursed, and then also getting the dispensing fee included as well, which ranges anywhere between $9.80 and $14, depending on if you're a high market chain versus one of the rural independent pharmacies and the amount of volume that you do. So that is in his possession. He's submitting it by the 27th to start the process for writing the bill language. And it's been a long, challenging process. Myself, I'm the only staff person for the Oregon State Pharmacy Association, and I've been joined by 7 or 8 pharmacists that are taking time away from their pharmacy to be in Salem for these meetings because it's important to them. It's their business, and they're trying to make sure that they stay in business to care for their patients and their volunteers. And on the other side of the table are lobbyists for the insurers and for PCMA, which is the lobbyist group for those 3 big PBMs. And we're going back and forth about all of these different things. I'm like, you guys are doing this because it's your job and that's what you are paid to do, and you're all very good at it. That's why you're working for these companies. But I'm like, we're going up against you guys, and it's David versus Goliath, because we're trying to stay in business and do the right thing for the patients. So yeah, it's been a frustrating process, but I'm glad we're done with that now, and I guess we got the 2025 legislative session to look forward to. So, but with that, we're hoping to pass our PBM bill, obviously, and get a chance to do reform. So that's kind of where we're at today. We had meetings with some of the legislators to discuss what the elements were of our PBM bill. The biggest part is having that reimbursement to pay for the cost of the drug plus the dispensing fee. The other elements, there's another 6 of it, but one of them is spread pricing, and basically it's the cost that the pharmacy receives, and it's what the insurance company gets charged, and the PBM keeps that amount. So say the pharmacy receives $10, and the PBM tells the insurance company that they gave the pharmacy $100. Well, they go ahead and keep that $90 difference for themselves. So it's one of the elements of how they make money, how they make $200 billion a year, and why they're all in the Fortune 15 companies. So I don't know, Roberto or David, do you guys have anything that you want to add about PBMs and what we're looking at? David, you and I had a chance to talk last week about different elements and what you're seeing. So
sure.
if you want to add
Hi,
something,
everybody.
feel free.
My name is David Davy Singh. I have a store in Cottage Grove, Oregon, and we have a very busy store. And for the first time, I've been a pharmacist for about 32 years. Practiced my entire career in Cottage Grove, and for the first time, I am really concerned about whether we will make it with the kinds of reimbursements that are coming through now. From the PBMs. It's gotten worse. What essentially they've done is that Medicare passed a law last year saying from 2024 you cannot retroactively go back and take back money on a claim that's been processed. So the PBMs reluctantly agreed to that because they had to. But in response now for 2024, what they did is they came up with another fee. Well, the fee, nobody really knows what that fee is. It's not defined anywhere. But essentially in practice, what we see is that they're reimbursing us less than the cost of the drug and taking that difference to make up for the losses that they incurred last year. It's pretty criminal, really, and easy to easy to see how wrong it is. But to get legislators and the government to make these changes takes forever. And the problem is we don't have forever. I am at the point now in my business, which runs, we do $10 million in sales every year, and there is nothing left at the end of every month when I pay my staff and I pay my bills. There's just absolutely nothing left, and there's really no point in being in business, from that perspective. So PBM reform has to happen for the sake of pharmaceutical healthcare in Oregon. And if it doesn't, I really don't know where it goes. So that's my 2 cents.
Hi, I guess I'll chime in. My name is Roberto Linares, and I'm an instructor at the College of Pharmacy here in Corvallis. And but I've also worked in community pharmacy my whole career. I worked at Bimart for 30 years until they closed all their pharmacies. So I was a little bit a victim of basically some of these issues that Brian and David are talking about. I still work part-time at different community pharmacies, sometimes at Rice's here in Corvallis and some other pharmacies that I know the owners like David. And I see the struggle, but I think Brian and David have talked a lot about the PBMs and the struggles and I can't really add anything to that, but I think I will add what I see, especially in the community pharmacies, is the role that pharmacists play is so important for public health. And I think we can all see that from the COVID pandemic, that having a network of community pharmacies throughout the state and throughout the country is crucial. And when we lose those, you lose valuable healthcare. And I've seen David's pharmacy operate, and I've seen Rice's pharmacy operate. And the pharmacists, they don't just dispense drugs, they really take care of people. And in order to do a good job of that, you have to have a business that is not losing money every time with every prescription. And so I think that's the challenge, is to do community pharmacy correctly. You have to have enough staff. You have to have good trained pharmacists who are not struggling to fill hundreds and hundreds and hundreds of prescriptions every day. You have to have a pharmacy where people know their patients. They take care of the patients. You're not just getting drugs through the mail where there's no interaction with people. And many of you who probably work or who go to the pharmacy or go to community pharmacies, you probably see that, right? People, the pharmacists there know your name. They know the medicines you're on. They're able to do those things. And that's what I worry when we lose a pharmacy in a town, whether it's Corvallis, which has lost several pharmacies in the last 5 to 10 years. And that causes issues, and that puts more strain on the other pharmacies that are already present. So I can't really add anything to the PBM issues because Brian knows that better than I do. But I see the impact on community pharmacies and the community.
All right. We have a couple of folks from Rice's in the room here with us. And
Can you?
I think they both might like to say something or
Yeah, I'd like to.
try to speak into this.
Can you hear me? I'll just walk this way. Yeah, hey Roberto, thanks for not trashing Rice's. Yeah,
The microphone.
yeah, I'll sit here just for a second. And then we'll trade back. Hi, I'm Tom. I'm at Rice's and, Roberto, thank you for that. That's a super important piece of the puzzle. And I'm gonna jump back into some numbers. Just because I cooked them, I got them together before this meeting and, so just to give you guys an idea about how real this is. And so we're gonna call this a, anonymous, independent pharmacy somewhere in the Willamette Valley. So, January to August, so that's 8 months out of a 12-month year. We sold 10,245 prescriptions below zero. Those are negative numbers. Okay, the total on that was $77,982 on those 10,000 prescriptions.
7,000?
77,000.
That's different.
982, so $78,000. And please make sure that you know that this is an anonymous pharmacy. We had a total of 50,000 scripts for that time period. It cost us $2.6 million to bring those drugs into our store. In 2020, the cost to fill a prescription was somewhere between $9 and $15. So I picked $13 as a number that it costs to keep my lights on and mostly do my payroll. So, you know, there are a lot of people in our town or that work at my pharmacy that are dependent on us to be open for a livelihood and a career. So let's extrapolate a little bit. So let's say that all of those payments that were less than $13 were really negative because they are. So then we get to 30,000 prescriptions sold under our cost to do business, which is about 60 to 70% of our business, which we had talked about earlier. And when you add that into the total, I'm projecting that we're gonna lose $315,000 right at the cash register. Before anything else happens, we're gonna lose $315,000. For the 12-month period of 2024. And yeah, it is, it's pretty grim. And we're working on the state level and the federal level with Senator Wyden, and Kate's been working with Val Hoyle, and the representative, Senator Wyden. You're working with the state, but we got to get this stuff across the finish line, because if we don't do it soon, we're going to be exactly where Roberto says we're going to be. You know, today we filled 430 prescriptions, and I know lots of people by name. I mean, they know who I am. I took a week of vacation. Everybody asked, where have I been? So I think it's important, even in a medium-sized town, that we have that connection, you know, all of my staff and our patients. So that's those are grim numbers, and unfortunately they play out. I mean, we have a pharmacy in Staten. I don't have it, somebody else has it, but they're filling almost 1,000 scripts a day, and they're struggling to make payroll to pay their employees. So, and meanwhile, we get back to where's the money going? It's going to PBMs. So, if you guys can tell your friends, and if you want to network, come over to the independent pharmacy in Corvallis, and we'll have a chat and brainstorm. Thanks.
Kate, did you also want to speak?
No, I mean, they've said it all. Hi, I'm Kate, I'm a pharmacist, and an OSPA member. I guess just to reinforce that it's very dire. It's very dire, and then just to watch prescriptions being sold below our basic cost. Not to mention the lack of a dispensing fee. We have so many patients who can't do mail order. You know,
Right.
and another thing about the PBMs is they're practicing medicine. They are deciding which drugs patients can have.
How?
Don't get me started. We can talk about that later, but that's what, this is a fight we need to get everybody in on. So thank you.
This is an aside, but assuming for a moment that Dan Rayfield wins the job of Attorney General, we need to keep hitting him with that phrase, practicing medicine without a license. Because really it ought to be illegal, just for that reason alone, but I'll stop right there.
So we at Mid-Valley, especially on the legislative committee that I sit on, we're following 4149. So my question is, I watched the healthcare committee meetings, and when that amendment came up that stripped the real cost containment part of it that would have helped you folks out, even the Republican voted against it because he didn't want to see that stuff stripped out. So I'm having a hard, and when it went to the House floor, there was only one person voted against it. Granted, it was the stripped down version, but it seemed like everybody was kind of recognized the problem and wanted to do something about the problem. So I'm just wondering, why did that? Do you have any insight as to? I can't remember if it was Rep. Nathanson or Goodwin or who stripped that out, but I mean, it looked like it was like bipartisan support all the way on that bill. So why did it get watered down?
Okay, so going back to 2023, we had our House Bill 3013 that ended up getting a 14-11 vote on the last day of the legislature, which would have passed, but you need 2/3 majority in order for it to become law. So we lost by 2 votes. That is the year where there was the 6-week walkout by the Senate Republicans. And so the Senate Republicans went ahead and walked out, and we didn't have enough time to clarify the issues with those that weren't in the Capitol during that time. So that at that point lost. And so our plan was to take that exact same bill back to 2024, short legislative session, keep the exact same language. Everybody understands it. We have the people that voted no in 2023 that had confirmed that they would go ahead and vote yes in 2024. And then we got to, it was right around Christmas time, and we talked to Nancy Nathanson, and there was leadership that didn't want any controversial bills to come up because they wanted to make sure that the Senate Republicans stayed for the entire 45 days rather than having any controversy. So our bill got gutted, and it got gutted significantly. And you're right, even coming out of the House Healthcare Committee, there were people that didn't want to vote for it because they're like, this doesn't do enough. It's not going to fix the problem. Why would we have a bill that's not going to be substantial enough? And they had to take a break, and they came back after that break and had another revote to make sure that they had the votes to pass it on so that it could continue going, because it does have some good elements, which includes the enforcement piece at DCBS. So they hired, or they're in the process of hiring 5 staff that will help with enforcement of PBMs when the pharmacies submit complaints, and have that process to make sure that they're no longer doing whatever they want, even though we have our laws passed, but they just go ahead and keep on being bad actors. So 4149 passed, but during that time, like I mentioned, Rob Nose said that he would bring back a strong bill for this legislative session and bring something that is going to help keep pharmacies open and help the patients be able to access their drugs.
Okay,
Okay, thanks. So do we, so besides, you know, lobbying our local representatives, should we, you know, keep advocating with Rob Nose to hold to that and not, but I mean, you know, because it sounds like a dire situation just from what Rice's was talking about. I mean, we're losing pharmacies, you know, as we speak, we're losing pharmacies. So, I mean, it doesn't sound like we can afford to wait on this. So what do you advise that we as citizens can do to ensure that there's no backsliding on this?
Keeping the pressure on the legislators, because you know it's got to get through both the House and the Senate, obviously. And as I mentioned, these are billion-dollar companies, and they got well-paid lobbyists, and they're going to have the League of Oregon Cities coming in opposition because they're going to scare the mayors that this is going to raise the premiums for the city employees, and then they're also going to scare the unions that this is going to increase their costs as well. You know, all of this is dependent on whether or not the PBMs want to pass along that cost or not. They're obviously very profitable, and I don't think that Oregon is a state that's going to make a big impact in their profit line. So,
Who has the question?
Susan has a question, and then Bobby has her hand up. Susan, did you want me to just read your question from the notes?
Yes, please.
Okay. Brian, what Susan wants to know is how your organization supports people with disabilities with mental health issues. I mean, how does your organization support those people from a pharmaceutical perspective?
So we are a community pharmacists association, and so we represent the pharmacists, and the pharmacists are the ones that help the patients.
Okay, understood. Is that okay, Susan?
Yeah, but I forgot one word is diabetics.
Oh,
I am diabetic.
okay, yeah. But so Brian represents the pharmacists, not a direct advocate for patients. But thanks for your question, Susan. Bobby?
Hi. This sounds like a simple problem in a way, but it was presented as a very difficult and complex problem. And I understand the complexity might have to do with the way the individuals interact with each other and the names of the groups that are on one side and the names of the groups that are on the other side. But it does sound, you know, and I really thank my friend for clarifying it in his question. I think he did a great job in clarifying it in my mind when he asked the question about what can we do. Is it that simple that we have to pass this bill? And it sounds like you said that when a bulk of people walked out, was it 2 years ago now? That's what did it in. If they had not walked out, do you think they would have passed the bill? And why does it require more than a simple majority? Who decided that it would require more than a simple majority to pass? I'm just confused about that, because it seems like if you raise that majority, you're going to have a much harder time, really. And gosh, it sounds like there could be a simple solution to this. And I think all of us here would like it to be a fairly simple solution.
Yeah, so I'll ask Alex maybe to jump in on why it's 2/3 if he wants to take that one. But to answer your question about the Senate and the walkouts, yes, it would have passed if we had a chance to do it. There was a Senator Hansel from Eastern Oregon. He was away at his grandson's wedding the weekend that the vote took place, and we know that he had a close relationship with pharmacists in his area and would have voted yes. There's another senator that was in that same Eastern Oregon area, and I can't think of his name right now, but he would have voted yes. He was extremely upset that he was lied to by the other lobbyists. And then there is another senator who voted no, but he was going through some life challenges with his wife and some medical issues. And so he thought he actually voted in support of the bill after we talked to him. So, I mean, yeah, so it would have gone in our favor if we would have had people in the had the chance to have those conversations with the senators.
Wow, it's just so close.
Yeah.
Oh, it must
Yeah,
be
and
very hard.
yeah, and there's actually, I can't remember what the name of it is, but I think it's called consideration or something along those lines, where if they would have done another revote that day, there was the chance that we had already had a couple of people that recognized that they made mistakes and were going to vote in favor of it, which would have solved everything. But there was also a bill from the governor's office that they were not interested in hearing again, so they chose not to hear ours as well. But Alex, for that 2/3 part, that's Oregon law, I believe, correct?
I thought that related to direct like taxation measures and stuff like that. So I can't really and maybe somebody else knows a little bit more about that, the financial impact, but I didn't think that would require a 2/3 majority. So maybe somebody else with more knowledge on that can help out. I thought that was more I think that was more things that directly impacted like taxation or things that that are entrenched like constitutionally. So yeah, so I'm not sure about that. I'll look it up though and let you know.
Yeah, I know it had to get to 2/3. I'm like, we have the majority of the votes. It's 14-11. I'm like, we win, and then like, oh no, you don't. Yes, it was a roller coaster of emotions.
Wow.
Anybody else online that has a question? I want. Okay.
I just had a quick question. It's not directly related to PBMs, but I was just curious with the Kroger-Albertsons merger that's, as all these attorney generals in the states are battling it now, and then there's the FTC. But I'm wondering, it seems like most of the media stuff I see isn't talking about the impact on pharmacies. Like, and I know it's not, your independent pharmacies, and we're talking about Safeway pharmacies, but it sounds like that's gonna, I'm just wondering what your take on that is as well, because it sounds like that's gonna, again, to your point about us having the second worst access in the country, which is pretty dubious distinction. It sounds like it's going to make that worse, but nobody's really playing that up. So I'm just wondering what your take on that is.
Yeah. So as far as the PBMs go, we're in it together. We're in it with the chains. We're in it with the grocers. All of us are working together for this. And you're right. The merger between Kroger and Albertsons, our current board president was sitting on a task force that evaluated what that meant for the pharmacies, and they unanimously voted against it from the OHA standpoint, because there's nothing good that can come out of it. They were saying that the other company's CNS that's being included was considering, or that they have brought on pharmacy staff from previously that were part of Rite Aid that would help manage the process, and that the Piggly Wigglies wanted to be in the pharmacy business now and that kind of thing. But my you know, when Albertsons and Hagen's did their merger, that shut down a lot of pharmacies 8 years ago or whenever that was. So that's a huge concern that they're just going to fumble it again and not be able to make that merger work. In addition, I have heard that even if the merger doesn't go through, that there's the potential of 40 Safeways closing as well for their pharmacies. So we're in a tough position if we don't get this bill passed.
Thanks
So
much.
Yeah.
I have a couple of questions. Is there, I've heard that there's a federal bill working on this, but can you elaborate on that? The number might be House Bill 9096. Have you?
Is that House bill or Senate bill?
I think it's a House bill.
Okay. So I was in DC last weekend, and I met with Wyden's office, Merkley's office, and then Lori Chavez Dreamer's office. And you know, the PBM bill is something that Wyden's staff believes can get passed during the lame duck session. But they also need the pressure to stay on. So I'm not sure which they were referring to Wyden's Senate bill rather than the House bill. So when it comes to the federal stuff, I try to let our national partners manage most of that, and I just stick to the state's issues. But I do. I'm hoping, and there should be something that passes before the end of the year.
I can speak to that, to the
Okay.
HR 9096. I'll get over here.
No, right here.
Right here, okay. HR 9096, right now it needs co-sponsors. It was, initiated by a representative from Pennsylvania and a representative from Tennessee. It's got strong bipartisan support. It's at the very, very beginning stage. It's called the Pharmacists Fight Back Act. It's the most extreme, well, not most extreme, most wide scope of PBM reform that we've seen to date. It needs co-sponsors right now by Thanksgiving. It needs, I believe, 25 Republican and 25 Democratic co-sponsors to move on. So I have been encouraging my colleagues and patients and anybody who cares to contact your federal representative and ask them to please co-sponsor.
So that, for us, that would be Val Hoyle.
Correct, yeah.
Okay.
I invited her to this Zoom call,
Aha,
but I don't think she's here, or,
Yeah.
well, her, one of her
staff, yeah.
It doesn't have a number yet?
1996.
Oh, that's the one.
HR 1996.
HR? Okay.
Yeah, I think HR, House Resolution. Yeah, if you Google that, you'll see the whole, it's right there. Yeah.
Okay, my follow-up question, Brian, for you. So our representatives in the legislature, Sarah Gelser in the Senate, and it's sort of a foregone conclusion, Sarah Finger McDonald will be our new House representative, since she has no opponent. They're likely to be supportive, and we certainly can lobby them. Are there others, though, that you would say it would be good for you to make contact with, or by virtue of being out of their district, would they not like that?
That's a good question, because I hear both sides of things. My lobbyist that we contract with, you know, she always talks about the constituents in the district, and they're the ones that have the most powerful voice. But at the same time, like I feel like their staff and the legislators can't keep up with everything and exactly what your address is. So I feel I feel like if you can reach out to everyone, that's always a good tactic. But my lobbyist always says the constituents and talk about where you live. So
Sue had another question, Mark. If you did you have
No, go ahead.
Okay, it says, I talk about, it's not much the time, but I said, what about Fred Myers has problem with staffing? And that's where I go.
yeah, and that's the thing is the staffing. You see the reports of pharmacies being closed and people not able to get their medication because of limited hours and those types of things, and that all goes back to the reimbursement from the PBMs. They don't reimburse enough to provide so that people can that businesses can staff up, and then at the same time you have the other pharmacies that are closing, and the patients need to get their drugs somewhere, so that's forcing more patients towards those remaining pharmacies that are open. So yeah, I go back and blame the PBMs.
Thanks.
Okay.
I'm just kind of curious.
Say, I've got a report, Mark. I just went back and it's in the Constitution. That's what I thought. So a 3/5 rather than a simple majority is required for anything that raises revenue. So I thought it just related to taxation, but I was close. But so I guess even though it's not really a tax, I guess within the, I mean, there must have been something in the legislation that maybe raised revenue for establishing the, well, I mean, it established a regulatory body, so they must be, paying DCBS for that. But I mean, that was in the bill that passed, so I'm not sure what. I mean, they definitely had much more than the 3/5 for passing it, so maybe that wasn't an issue. But anyway, for general edification, it's anything that raises revenue in the Constitution. It requires a 3/5 vote in both House and Senate.
Thank you. Thanks for doing that legwork. All right.
Well, do PBMs have the authority to make patients or pharmacists substitute medications for patients? And can they completely decline paying it all for they just deny, say the patient doesn't need the medicine? Is this something too? That's really interesting.
Could you repeat? I don't think everybody can hear you.
Yeah, you might have to move
Can
up
you come closer here?
to the mic.
I was just wondering if PBMs have the authority to tell patients or tell the pharmacist they have to substitute a medication, or if they can deny a patient a medication saying they don't need it at all.
As far as denying, I'm going to defer to the folks with Rice Pharmacy to answer that one. But yes, the PBM can determine what the medication is that gets dispensed, whether it's brand versus generic.
Yeah, I can speak to that. Yeah, whether it's PBM or the insurance company, prescriptions get denied all the time, and there's usually a process for that. People have to meet certain criteria. So let's say something as benign as adult acne. If you're over the age of 21, they're not going to pay for it. It's cosmetic. And then it goes on from there. A lot of times people have to fail on lesser cost drugs, even though they may have a lot of side effects that are debilitating. They still will force the patient to trial and fail on older, less expensive medications. Doctors have to jump through hoops to do that. Pharmacies have to jump through hoops to get things paid for. Sometimes there's just an outright denial. You don't meet the criteria at line 487 on that diagnosis code, so we're not going to pay. You can go pay for that yourself. We're not paying for that. It's not part of what the lawyers draw up in terms of the payer, the patient side of the pharmacy world. So Roberto, I don't know if you're still there. Does that sound about right?
Yeah, no, I would agree with that. I mean, I would say there's somewhat of a role to help control costs. I think what we see a lot of times is there's delayed care, there's an inability for patients to get their medicines, and there's a lack of understanding, right, of why can't someone get their medicine in a certain time fashion. And I think Brian addressed this earlier, right? Initially, when PBMs came about, they did play a role perhaps in controlling costs, but they've really gotten away from that. And I think that's where the problem is now, is they're not they're not playing the role that they initially were kind of brought up to kind of play.
Okay. Mike,
If I can just say something, this is David. The classic example of what Roberto just said is, and Mike is you the PBM says that you must dispense a brand name drug, even though there's a generic that's available that's significantly less. And you think, well, wait a minute, why would you do that if you're there to control costs?
Mm-hmm.
Well, because they get a kickback from the manufacturer to put that brand name drug on their formulary, and they get all of that rebate. And keep in mind, a PBM does not buy the inventory. We buy the inventory, but they get to keep the rebate because they negotiate with the manufacturer of a much more expensive drug to keep that rebate in their pockets. So the whole system is broken. And like someone said earlier, this is an easy thing. What's the big deal? It is an easy thing, but nobody's doing the right thing.
Well
Yeah,
said.
I think that's the best example that you could come up with. That was good, David.
Okay, Mike Huntington has a.
Yeah, I just, my dad is a pharmacist and mom ran a corner drugstore. And he basically had his own family practice, especially for Spanish speaking people. And, my nephew, was in pharmacy for a while, and I call it now moral injury of saying, no, you can't, you don't qualify for this. The surprise at the counter, the stress of pharmacists and pharmacy techs. My question is that what you call moral injury? How much of that is contributed by PBMs? I know there's, even without the PBMs, there would be a lot of that, but any comment?
I'm sorry, can you say the question again? Whether or not pharmacists and technicians can what?
Well, whether you suffer what we now call moral injury, it used to be called burnout.
I'm sorry, you broke up. It used to be called what?
It used to be called burnout. Now it's called moral injury.
Oh, burnout. Yeah, yeah, burnout is a problem that we're seeing a lot. You know, the pharmacists are going to work for 12-hour shifts. They're on their feet all day. There was a point there when they weren't getting bathroom breaks and lunches, and you know, there's been improvements, and a lot of what we see isn't with the independent pharmacies when it comes to those, but more the chain pharmacies. So independent pharmacy just in general is a better place to work than it is a large chain, because of their metrics that they have and those types of elements. But yeah, there's a lot of burnouts, unfortunately. With the way that pharmacy is currently, the number of students actually going into pharmacy school is starting to decrease nationwide as well. So we have a lot of people that are retiring, and then you know, it's I guess if you are a pharmacy student, it's good for you because you'll be able to get a job pretty easily coming out of school. But you know, there's not enough to fill the backfill of everybody that's leaving the profession.
Thank you.
Thank you. We're gonna move slowly towards a wrap up here. But are there any last questions online? I think we've got the ones in the room, but.
Susan has her hand up. I've got two here.
Oh, okay, go
So
ahead.
Anybody else wants to go first? Well, go ahead, Mac.
Go ahead, Max.
Susan had her turn. All right. First of all, I'd like to offer a metaphor, if I don't lose my voice first. And that is that the PBMs are acting as a parasite on the host organism, which is a system without PBMs. The drug manufacturers, the insurance companies, the pharmacies, and the patients. And they are sapping the lifeblood from that organism. If this metaphor is useful to you, go with it. All right. So that.
Yeah. So it's funny you mentioned that because the National Independent Pharmacy Organizations, they're called NCPA, National Community Pharmacists Association, and they are running ads currently in DC that have a leech in their ads. So you're right on with that.
I'm thrilled that someone else came up with it first. Okay, the other thing is, and this is, I admit, is changing the subject somewhat, from legislation to what an individual can do. I, in particular, am in the process of choosing a prescription drug insurance plan. All right. First of all, does there exist a plan here in Oregon that does not involve PBMs?
Yes.
All right. What is it? I want to buy it.
So if we were in the, and it's gonna be challenging for you if you live in Corvallis, from what I remember about living there. If our bill passes, there will be a carve out for Kaiser, because Kaiser is their own system and they don't have a real PBM entity. They're Kaiser. So yeah.
Okay. Salem's not that far. Okay, but
Yeah.
that won't happen unless this bill passes. Is there any way, if not to avoid PBMs entirely, to at least minimize the atrocious effects that they have in my choice of a drug prescription insurance plan?
Ooh. David or Roberto, you guys process claims. Any advice on that?
What's the specific question again?
All right, I want my money to go to the pharmacy, the PBM. Is there any way I can buy a prescription insurance plan?
Well, I think we're somewhat prohibited. And am I correct, David, in that pharmacies are somewhat prohibited in directing people in any particular direction?
Yeah, it's a CMS violation to steer someone to a particular plan that benefits you. Even though Walmart has Humana with tables in their stores, encourage people to sign up. You know, so it's so convoluted. It's amazing.
So pharmacists are prevented from giving good advice.
Yeah, and that's one of the things also that we haven't talked about, but there are gag clauses in the PBM contracts that prevents pharmacists from being able to share information with the patients, and also they're not allowed to contact the insurance companies directly, or they're going to get a cease and desist letter. So yeah, like pharmacists are there to help the patients and they want to do what's best for them, but they are prohibited by some of these contracts that are in place.
Mike,
the PBMs know that they have pharmacies over the barrel because they give us take it or leave it contracts. If you don't take it, we'll just send people across the street to Walgreens or to Safeway or to Costco because they take anything. And so pharmacies, particularly independent pharmacies, who've taken care of people for years, are just kind of left, struggling through that whole thing. Look what they did with TRICARE. Express Scripts made the TRICARE contract so bad for pharmacies, independent pharmacies, and even chain pharmacies. Why? Because these PBMs have their own pharmacies, their own mail order pharmacies. And I had one lady who came in, and she was an Express Script patient, and she wanted to get a 3-month supply. And I told her I couldn't fill a 3-month supply for her because I would lose $200. I could fill a 30-day supply, and I would lose $10, but I couldn't lose $200 and keep doing this to stay in business. She called her ESI, Express Scripts, and complained about it. They called me and says, you're in violation of your contract. I said, I didn't sign up for a contract that undercut my cost by $200. What are you going to do about that? Well, you can get a lawyer if you want and fight that, but you're supposed to fill a 3-month supply. And then she added that, the agent added, well, if you're not going to do it, we'll just have her send it to our mail order pharmacy. So that's the kind of thing that they, the tactics that are used. And so more and more, the mail order pharmacy may be convenient in some cases, but mail order pharmacy is not the true practice of pharmacy. In Oregon, we have a law that says that you have to counsel. It's mandatory that you counsel a patient on every new prescription that they receive. If you don't, and you're reported, you could lose your license, or certainly receive a warning. And if it happens again, you could lose your license. How does mail order get away with it? They send you all this paperwork that nobody can read, and you try to call them, and nobody answers the phone. But yet that's acceptable. Yet Amazon now goes off, and Amazon's going to take over the world. And what happens to patient care? Well, who cares about patient care? We say it, but we don't do it. We don't practice it. From the legislative side, it's very frustrating.
Yeah, I think we all feel the frustration. I'm gonna give Mike one more turn and then we'll wrap it up.
Yes, is Array RX a more benign form of PBM? And does it help independent pharmacies?
Array?
Array RX.
What is that? Array is.
So Array RX is managed out of Salem by the OHA.
Health. Yeah.
This would be a huge conversation that there's they have a couple of states that they're on board with right now. They're the OHA PBM.
Any comment, or is that too controversial to comment on? Is it a good thing or bad thing for me as a consumer? I don't like to say consumer, patient.
Well, so.
I missed the first part of your question.
Yeah.
Tom can answer.
Well, so Array RX is a reimbursement plan for the pharmacy where we don't lose as much, or and so, like, for instance, Rice's, we do not accept GoodRx at all because they don't pay anything for GoodRx. Doesn't get any doesn't put any value into the system. What they do is they charge the patient less money, and then they take all of the money that we would have normally made as a profit and they suck it off.
Array
Array
That's
RX
GoodRx.
is like a GoodRx light. They do take some, but they don't take as much as a GoodRx. So we can look at that and we can make a decision whether we'll accept that or not. So that's how it works for the pharmacy side. As the patient side, I would think that if a pharmacy were willing to take your Array RX card, an independent, then they're probably staying above water on it, probably. So there's so many, with a, 30,000 drugs, or the 20,000 we have behind our counter, everyone's different. It's all, has different costs, different margins, so on and so forth. So it's very difficult to give a blanket statement. But it is one that is, one that on some medications we do break even. So we're super happy. We're elated when we break even.
Wow.
Yeah.
Wow.
Yeah.
So, Brian, I have a wrap-up line of my own, but would you like to summarize or wrap up in any way?
No, I just appreciate you guys being willing to invite me to this meeting, and Mike, thanks for making the arrangements. It's been a great conversation, and I'm glad that we had this opportunity, and yeah, I hope that we can continue talking and work together going into the session. So thank you guys.
Yeah, I really hope you'll keep us informed, and if there's a moment when people need to flood in, some feedback or whatever, we would like to know that and help do it. I'll just say, I think it was Roberto who mentioned community pharmacy being, working for the good of the community. And I will just say that I personally have experienced that with Rice's. One day, my wife, the assistant to a doctor, called in the wrong medication, which she would have bought and taken. And they caught it at Rice's and said, "Do you have this or this?" And she said, "No, the opposite." And they said, "We'd better call your doctor because we think this could kill you."
Oh, my God.
And the doctor verified that. Yes, this is a terrible mistake. Here's the right medication, da, da, da. But that's what pharmacies can do for communities. So this is an important topic, and we appreciate you dedicating your life to it.